Okay, shall we start?
Yes, sir.
Okay, so good evening to all of you.
Good
Today-
evening.
Yeah, good evening.
Yes, sir, you can start.
Yeah, thank you. So today I'll be presenting two short cases first. First one is not that good. Second is a really good case I'm seeing for the first time. That case is given to me by Dr. Madhuri. I'll just go to my share screen, just 1 minute. So is my screen visible to you all? Screen is visible now?
Yes, sir.
Yeah. So this is a story of a man, about 35-year-old man. About 3 years back, he noticed edema of both feet. He consulted a doctor who took an ultrasound of the abdomen, followed by CT, which revealed a huge mass in the abdomen and advised surgery with perceived risks. The patient denied any surgery, telling that no one ever guaranteed the outcome of the surgery. About 1 year back, he developed retention of urine and was on a catheter since then. Again, he consulted doctor, they advised surgery. Again, he denied for the reason the same. Nobody was guaranteeing the outcome. So presently, he has come with difficulty in walking for the last 2 weeks in the form of imbalance and loosening which suffers from while walking. This is a story of the patient. It's a short case. Upper limb was
അതോടെ പിടിച്ചേ കേട്ടോ. ഈ പാദം മുകളിലോട്ടെടുക്കെ ശ്രമിച്ചു നോക്ക് എത്രത്തോളം ഇങ്ങനെ പൊക്കാൻ നോക്ക്. ഇത് പൊങ്ങാൻ നോക്ക്. പൊക്കിക്കാൻ നോക്ക്. ഈ തള്ളവിരൽ പൊക്കിക്കേ. ഇത് പൊക്കാൻ നോക്ക്. പൊക്കി പിടിച്ചോ. പൊക്കിക്കേ. ചവിട്ടിക്കേ. ചവിട്ട് ചവിട്ട്. ഇതും ചവിട്ടിക്കേ. ചവിട്ടിക്കേ. ഇനി കാലകത്തി വെക്കണേ. അടുപ്പിക്കാൻ പിടിച്ചോണോ? പിടിച്ചോണോ? ഇതിനകത്ത് പിടിക്കണം. ഇനി ചേർത്ത് വെക്കണം. അകത്താ സമ്മതിക്കരുത്. മതി. ഈ കുത്തുന്നത് അറിയാവോ? ഇതോ? ഈ കുത്തുന്നതും ഇത് വ്യത്യാസമുണ്ട്. ഇതും തമ്മിലോ? മുകളിൽ കൂടുതൽ താഴെക്കുറവ്. ഇതറിയാമോ? ഇതും വ്യത്യാസമുണ്ടോ? ഇപ്പോഴോ? ഇപ്പൊ എന്തോന്നാ? ആ വൈബ്രേഷൻ ഇപ്പൊ ഉണ്ടോ? ഉണ്ട്. ഇപ്പോഴോ? 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 ഇല്ലെന്നേ പറയാം. ഇപ്പോഴോ? അവിടെയുണ്ട്. ഇപ്പൊ ഉണ്ടോ? ഇപ്പോഴോ? നൂറ്റിരിക്കണോ? വെച്ച് പറ. ഇപ്പൊ എങ്ങനെയാ? ഇതൊക്കെ അറിയാലോ.
bilateral control heat. Only mild waddling also is present. So findings confined to both lower limbs. Edema both feet, left more than the right. Tone normal. Power, weakness of both dorsal flexors of the angle. EHL, flexor pollicis is long, flexor hallucis is longer, and plantar flexor is more on the right side. Weakness of both hip abductors. Other muscles were glossally normal. Sensory system impaired pain, vibration, and JPS over both feet, more affected on the left side. where patient was inconsistent in his reply most of the time. SLR negative, bilateral, mild steppage gait with warting. So where is a lock? It's a straightforward case. Where is a localization?
Kodaikanal syndrome, sir.
Yeah. Bilateral L5 radiculopathy Kodaikanal. But how to explain the edema on the both feet?
It's usually distal to the radicals get edema. If it's
Correct.
not due to other reasons.
Right, exactly. Exactly. That's the correct answer. If it's not due to other reasons, most likely you have to think away from a radiculopathy because Kodaikanal lesions will not produce edema on the feet.
That's true, sir. But sir, he has weakness of the glute also. The abductors also weak.
Yeah.
So
That cannot differentiate between a plexus versus radiculopathy. Plexus involvement also can produce glute weakness.
yes, sir.
Yeah. When you differentiate from sciatic nerve, we can read.
Okay.
But the point is that he had been having edema for long, much before the weakness has settled in. So probably edema may be unrelated. That way, the radiculopathy should be the first possibility. Okay, now that's not the interest of the patient. Now, this MRI brought by the patient taken 2 years back when he went to the surgeon and denied surgery. Look at the MRI. This is the MRI sagittal view. This is the T2, showing a heterogeneous huge mass in the abdomen with bilobed, one posteriorly from anteriorly. Then you can see the fluid collection here. This is the vertebra. This vertebra is only partially seen. Then it is coming anteriorly like this into the abdomen, into the pelvis. This is the bladder and this is the colon. Okay. Now I show the other picture. This is the coronal view. Showing again, this is the mass, this is the vertebra, this is the fluid collection. This axial cut, this is the mass, this is the spine here. And see what is happening to the spine now here, that is defect there. Here again, you can find out there is a deficiency of the upper part of the sacrum here. Here it's there. Here is totally sacrum is absent and the fluid collection is going posterior to the sacrum. And the mass is also coming out through that, defect. And this is the mass here. This is it coming out to the defective sacrum. This is the T1 contrast. Again, you can find out that's not enhancing with contrast. This is a sacrum ilium. This is sacrum, a defective sacrum coming out. This again is chart which I shown earlier. This is the T1 fat set contrast. You can see the mass which is not taking up contrast. And this is the fluid collection there. The CT of the lumbar spine, the CT scan showing that mass is coming out through the defective sacrum. And this is the sagittal cut. So this is the fluid collection. This is the mass. This is the defect in the sacrum. The fluid is coming like this. This is the bone cut showing that the sacrum is partly missing. So, what do you think? What do you think the patient is having?
Could be a congenital defect.
Yeah, most likely congenital defect. What could be the congenital defect?
Myelomeningocele, spinobite.
Yeah, this is a meningocele and there is a mass also. Okay. Now, this is a rare condition. That's why about the case, not very fantastic or challenging case. So, how did a conduction differentiate whether the plexus is affected or the root caudicum is affected? Because the mass is inside the pelvis, it can very well compress the plexus. Or the lesion is maybe part of the meningocele causing the caudicum and root stretching. So this is the NCS. Motor conduction decreased amplitude on both peroneae. tibial were normal, sensory potentials were normal, and FA latency is normal. So what do you think is the site of lesion now? It is radiculopathy. It is unlikely to be plexopathy. If it's a plexopathy, sensory potential should have been affected. So that is spared. So most likely radiculopathy. Now we know the lesion is in the caudate vein. So the MRI was repeated because this MRI was done 2 years back when he had, 1 year back when he had the retention. Now he has come with weakness. So the MRI was repeated now. This is such a sagittal view. This is CSF, the anterior one is the mass. This is the axial cut. This is the CSF collection. This is the mass again. It's a bilobe mass. This is again showing the picture clearly. This is CSF 1/1, and this is the mass. Bilobe mass.
സെപ്റ്റേഷൻ
This is the CT. Defect.
താഴെയാ വന്നേക്കുന്നത് ജിപ്സാന്റെ മുകളിൽ വരേണ്ട താഴെ സ്പൈനോബൈപ്പിലേക്ക് മുകളിൽ വരണ്ടേ താഴെ സ്പൈനോബൈപ്പിടെ.
So what is a final diagnosis here in this patient? It's actually a defective or congenital aplasia of the sacrum, and there is a meningocele and a mass lesion, which most likely an epidermoid, because epidermoid is often associated with spina bifida and related conditions. So this only to show you that the size of the mass can be sometimes associated with these meningocele like conditions.
Sir, but usually meningoceles are quite posterior. This is rather unusual. It is anterior, sir. So
It's actually going inside the pelvis. The defect is the whole sacrum is missing. Instead of going posteriorly, the meningocele has gone on to the pelvis.
And the mass is epidermoid.
The mass is anterior to that. Mass is most likely epidermoid one.
Do you agree for surgery now?
Yeah, he has agreed. He has agreed now. Yeah, now yesterday we did the surgery, removed the mass, total mass together. The other thing we will be doing it only at a second stage.
Are the roots intact, sir?
Root because they only the gastro surgeon did the gastric surgery. The other neurosurgeon is going to do the next one later. This is only a very short case to bring you. These things can happen in meningocele.
sir, what could be the cause for the edema in this patient?
Edema is most likely venous obstruction by the mass.
Congestion. Yeah.
In fact, next is a really good case. In fact,
Sir,
I have.
Gastro surgery, what is the gastro surgery in this case?
They did the surgery of the mass, removed the mass. The gastro surgeon means the surgical gastroenterologist.
Did he have any sphincter symptoms?
He had bladder problem. He had retention of urine for the last 1 year. That might have been due to the caudate infection itself. Okay. Next is a really good case. In fact, I'm seeing it for the first time. Even though I seen one video long back. And similar cases I had seen while I was in Kottayam Medical College. At that time, I was not able to make out what the condition was. Both the videos I will show. This is a story of a 16-month-old baby. She was brought by her mother for the complaints of deformity of both upper limbs since then. Mother did not give any other complaints. This is a boy, child. Look at the child very carefully.
సరే బాయ్ చెప్పు బాయ్ చెప్పు బాయ్ బాయ్ మాడు బాయ్ మాడు యారు నడకల బాయ్ బాయ్ ಮಾಡ್ಬೇಕು ಬಾಯ್ ಮಾಡು ಬಾಯ್ ಮಾಡು బాయ్ మా బాయ్
ఇది చూడు ఇది చూడు
బొమ్మ కాస్తుంది ఇగో ఇగో బాయ్ ఇంకో బాయ్ బాయ్
Look at the face. He's got both arms are flexed, elbows are flexed at the elbow and as well as in the wrist. And subsequently, you see they're all rigid.
ఏంది అట్లా చూస్తున్నావు
నార్మల్ బట్ ఒళ్ళ 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 ఒళ్ళ
Can you reduce the video?
పెన్ తోకు పెన్ తోకు నామదే పెన్ తోకు ఆబారి మా ఆబారి
పట్టుకో
గచ్చి 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 గచ్చి
పట్టుకో 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 పట్టుకో
ఇడుకో గచ్చి గచ్చి
పట్టుకోవాలి పట్టుకో
He's unable to open it.
నామదే
పట్టుకో 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 వదులు వదులు ఇచ్చే నాది ఇచ్చే
Reduce the video sound of the video.
కూర్చో కూర్చో
Now, see that same, both upper limbs are rigid. Both knee and elbows are flexed. The whole thing is like a rigid base.
కూర్చో కూర్చో
You can turn the whole thing like a logo with.
కూర్చుంటా లేదా సరే సరే
ಮೇಡಮ್ ಫೋಟೋ ಕಳಿಸ್ತಾರ ಮೇಡಮ್ ನಿಂಗೆ ಯಾರು ಮಾಡೋದಿಲ್ಲ
ఏం
Look carefully at the face.
ಬಾಯ್ ಮಾಡಿ ಬಾಯ್ ಬಾಯ್ ಮಾಡಿ ಫೋಟೋ ಉಳ್ಕೋಬೇಕು ಮಾಯ ಫೋಟೋ ಉಳಿಸ್ದಂಗೆ ಗುಪ್ಪು
See that both lower limbs are rigid.
పైకి ఎత్తమ్మా ఇట్లా నువ్వు చేతులు రెండు పైకి ఎత్తు
ఇట్లా
అట్లా కాదు ఇట్లా చేతులతో పట్టి లేపు
ఇట్లానా
ఆ, ఆ. అది
Get the
అయిపోయింది
like a logo with.
ಮೇಡಮ್
Get
ಅಳಬೇಡ್ದು ಅಳತಾರ ನಿಂಗೆ ಯಾರು ಮಾಡತ್ತಾರ ಅಸలు ನಿಂಗೆ
పడుకోమ్మా పడుకో ఒకసారి ప్రణీతానా
ಇಲ್ಲ
ఏ గుడ్డదాన్ని ఎందుకు
the abdomen muscles are also rigid.
ఏడుస్తుంది కదా మేడం అట్లా కనిపిస్తుంది
అట్లే అయ్యో ఉండు అయిపోయింది బొమ్మ
Any thoughts? Any diagnosis possibility?
Stiff baby syndrome, sir.
Stiff baby syndrome. Okay. Due to
Shorts
what?
jumble, sir. Shorts jumble.
Pardon?
Shorts jumble.
Ah, very good. Short Jamble syndrome. That's a perfect diagnosis. Now, I'll tell you the story subsequently. Now, look at the face. See, it's got epicanthal fold.
ಇದು ಕೋಟೆದಲ್ಲ ಸಾರಿ ಅಂಚುಂದು ಒಂದಲ್ಲಿ ನಿಂತಿದೆ.
I'll show you. I suspected only. I was not sure. I'll tell you. This is a pinched up lips. The lips are, this is a characteristic faces. Long philtrum and receding chin. And look at the picture from the literature. That's called blepharophimosis. The eyelids are smaller and the characteristic facial appearance. Just like this is the present picture and the photograph from the literature. This is a child I saw years back, about 25 years back while I was in Kottayam. I couldn't make out what the diagnosis was in this child. Exactly the same presentation. Picture really a long all limbs are stiff and rigid. With a high pitched cry.
ഇനി പതുക്കെ താഴേക്ക് വെക്കുന്ന മുറി കാണിക്കാം.
You can note the side like
ലിംബിടുന്നു.
everything is okay.
ഫുൾ റേഞ്ച് പറ്റുന്നു. ഓക്കെ. ഇത് മരത്തിക്കിടത്തേക്ക് അടച്ച് മസിൽ
The abdomen muscles are all hypertrophied and see the characteristic high pitched cry here. Okay, this is the picture of the child. You compare from the literature, the position. This is another typical case of short jambal. So the before phimosis, pitched up space, and the long philtrum, and the flexed posture of the knee and the elbow, and flexed posture of the trunk. This again some pictures from the literature showing the short jambal syndrome, classical blepharophimosis and pitched up space. So this, I could be doing the EMG at that time. It was, but at that time I don't know the EMG machine was available there. So in fact, this was done by Madhuri. He was kind enough to give this, share this EMG with me. This is the EMG of the patient. What do you expect of the EMG?
Continuous activity, sir.
Yeah, it's a myotonia. It's otherwise called chondrodystrophic myotonia. They've got chondrodystrophy as well as myotonic discharge. They can other discharges as well. So look at the discharges now. That's the myotonic discharge. Also got CRT in between. That is myotonia. In between there is CRT. That's a CRT. So what did you observe here? One persistent motor activity at rest, myotonic discharges as well as CRT. So this is short jambal syndrome called chondrodystrophic myotonia. This is a very rare condition, not very common. In fact, this is the second case I'm seeing. First case in Kottayam Medical, at that time I was not able to make the diagnosis. So a few, yeah, please. Anyone want to make any comment regarding the diagnosis?
Cry typical, I know.
Cry is very typical of a high-pitched cry. So, in fact, this is inherited as autosomal dominant and autosomal recessive. Most patients become symptomatic between 3 years to 10 years. They present with typical phenotypic features characterized by short stature, mask-like facies, epicanthic fold, receding chin, upturned nose, long philtrum, short neck, pinched face. That's very characteristic. Dorset ears, high-arched palate, prominent muscles, and high-pitched voice. The diagnostic findings are the typical facial appearance, muscle hypertrophy, and continuous muscle fiber activity. And they can have slow movements with arms in a semi-flexed position, as you can see in these two children. Toe walking, difficulty in opening the mouth, mild kyphosis, contractures at the elbow, spine, and pelvis, metaphase deformities, lumbar spondylosis, and limited movement of major joints. Electrophysiology shows normal motor sensory potentials, with motor and sensory potential, with characteristic EMG features in the form of prolonged and persistent discharges following needle insertion, repetitive discharges, high-frequency discharges, after discharges, and dye-bomber sound, and normal motor. They can have both CRT as well as myotonia and persistent discharge when you put the needle into the muscle. This again from literature, some cases of short jambal syndrome. So that's the case. So any questions?
Do you respond to any medicine, flecainide or something?
No, I think I have no experience in that. I have to look up the literature, which medication they will respond. This case, I got it only yesterday. Case showed me this case only yesterday.
Sir, how to differentiate from other myotonia, or can't we differentiate this?
Yeah, this is only because this is not only myotonia, it's a chondrodystrophy, the joint deformity, changes in the, and the contracture, the characteristic facial appearance. This is a one case where it's a spotter. Once you see that face, it's no other diagnosis other than short jambal syndrome. That pinched up face is so typical. It's pinched up here. So
So,
that
is there any hyper ecplaxia, this thing, any startles or hyper
no,
ecplaxia?
no, they don't have microns or something like that. Persistent muscle has become hypertrophied because of the persistent contraction. Just like congenital myotonia, you got a Herculean appearance of the muscles. Some this abdomen, look at the abdominal muscle of this child, it's all bulky and rigid.
So biochemical abnormality, what is
And I did not get you.
neurotransmitter abnormality? What is the abnormality?
But this is a channelopathy, this is an abnormality in the muscle membrane, causing a persistent depolarization. What channelopathy, I don't know. I have to look into that.
Probably anti-epileptics would be better in this case.
Yeah, right. Usually congenital myotonia is, I think it's a chloride channel. So this channel, I don't know which channel is affecting. Okay. Any other questions? Then I'll go to a long case, very long case, which has perplexed me for some time. This is a story of a 73-year-old diabetic. His complaint started 4 to 5 months back as insomnia, and he was started on antipsychotic medications from the psychiatrist. And his history of talking at night for the last 3 months. Is to jerky movements of the neck during sleep since 2 months. For the last 1.5 months, patients noticed to have excessive drowsiness spanning over the entire day. During the periods of excessive drowsiness, patient used to keep his neck flexed, goes on keeping the neck flexed. For the same duration, patients noticed to have imbalance while walking. How far it is due to the drowsiness, we don't know. And patients also noticed to have impairment in recent memory for the last 1 month in the form of misplacing objects and searching for them. For the same duration, for the last 1 month, patients also noticed to have hiccups. That is a major concern for him. That is involuntary jerky movements of the abdomen persisting even during sleep. There is no behavioral or personality changes. And he gave history 2-3 episodes of fall, query due to excessive drowsiness secondary to medication. One episode occurred at night when the patient went to urinate and the fall was unwitnessed. I think I'll go back to the history once again. Total duration is about 5 months, starting as insomnia and was put on antipsychotic medication. Then history of somnology, talking at night, and jerky movements of the neck during sleep. And that I will tell you, I will show you how the wife was demonstrating the jerky movement later on. Last 1.5 months, patients noticed to have excessive drowsiness during the entire day. And he goes on drowsy that his neck get bent progressively. For the same duration, patients also notice imbalance while walking. Patients noticed impairment in recent memory for the last 1 month in the form of misplacing objects and searching for them. Again, for 1 month, recurrent hiccups, involuntary jerky movements of the abdomen persisting even during sleep. So, and 2-3 episodes of fall with excessive drowsiness, probably secondary to medication. Now, this you can listen to the wife. She demonstrates how the jerky movements are occurring during sleep. That's the moment she gets. And he's sleeping, it occurs. That makes the patient awake. That's the moment. So these movements disturb him from sleep and wakes up because of the involuntary movement, these jerky movements of the neck. Now, rest of the examination. Failures were normal, ocular movements were normal.
ലെഫ്റ്റ് അപ്പ്
Like big
Down.
movements pursued were all.
താഴെ നോക്ക് മുകളിലോട്ട്. ശരി, പല്ല് കാണിച്ച് ഈ നാക്ക് നീട്ടിക്ക് മതി.
Just no pseudo theoretic movements.
ശരി, എന്ന് പറഞ്ഞ് മുഖ്യൊന്ന് പിടിച്ചേ.
His power was normal, not was also normal.
ഇനി പിടിച്ചോ. എൻ്റെ വിരലി തൊട്ടേ, വിരലി തൊട്ടേ, മറ്റേ ഗണ്ടിയിലെ. ശരി, ഇങ്ങനെ കാണിച്ച് സ്പീഡിൽ.
There's no kinesia. And this is a jerky one. I will show videos later on. It does not have the jerky one. No, it is less. Sometimes it's much more frequent. It is jerky one. Ask him to count again that occurs.
മതി മതി.
ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസം.
ഒന്നിനെ പറഞ്ഞ്.
ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസം.
ശരി, ഈ കാലിന്ന് പൊക്കി കഴിച്ച് ഇത് മടക്കിക്ക്. മടക്ക് മടക്കാതെ
Low limb power was normal. Low limb function. Reflexes small, just insensible. Triceps is very elicited, other parts are all sweaty, just elicited or even absent.
പകുതി മടക്കിക്ക്. അത്രയും വേണ്ട, പകുതി 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 അങ്ങനെ ഇരിക്കട്ടെ.
Ejects and ejects are also absent.
ഇതിനും കൊടുക്കണ്ട.
Take the triceps again. That was well elicited, all the requests were absent. And that was indefinite.
വൈബ്രേഷൻ
വൈബ്രേഷൻ ഇപ്പോൾ ഉണ്ടല്ലോ. അതേപോലെ ഇവിടെ ഉണ്ടോ? ഇപ്പോൾ ഇപ്പോഴോ? ഇതാ. ഇപ്പോഴോ? ഇപ്പോഴോ?
Celsius is
അറിയാണോ?
closely
ചുമ്മാ പറയരുത്. ഇപ്പൊ എങ്ങനെയാ? ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴോ? 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 അതേപോലെ ഇപ്പോഴോ?
Made some mistakes subsequently corrected. Maybe mild impairment, maybe.
ഇപ്പോഴോ?
That's the gate of the patient. They keep no. Sometimes it means that violent cannot. It's so frequent as simple cause breathless and making wake up at snack at 90% of all breathlessness.
ഇവിടെ നോക്കി.
Works almost normal, mild impairment, not impairment.
കാല് മാറ്റരുതേ. കണ്ണടച്ച് കാല് മാറ്റരുത്. തിരിച്ചു വാ.
Gate normal.
നേരെ വെച്ച് നേരെ നോക്ക്, നേരെ നോക്ക്, നടന്നോ നടന്നോ. നീ തിരിച്ചടക്ക്, തിരിച്ചടക്ക്.
Tandem was mildly defective.
ആ ഇങ്ങനെ വെച്ചോ. കൈവിട് കൈവിട്.
No, this is the home video sent lately. This is how it goes on. When you're sitting up, it goes on like that. Become can gives this fun like for hours together. And fast forward it. Ultimately it comes like that. So on examination, hymenal functions, he had some mild impairment hymenal function. The form of one attention was normal, but for the excessive drowsiness. Defective clock drawing suggestive of executive function was there. That's only abnormality. Memory language is normal. This is the clock drawing and ask him to draw 10 minutes past, 10 minutes to 3 o'clock. This is drawn the both arms. Rest of the examination, Kayla's are normal. Motor system, tone power normal, both upper and lower limbs. Detail all absent except bilateral tricep jerk. Sensation grossly normal. A repeated jerky movements of the abdominal wall, which you have seen, recurrent hiccups or diaphragmatic macronas. So summary of the findings. Mild cognitive impairment, mainly frontal. Excessive drowsiness, that is a main concern for him. And second is the nocturnal jerky movements of the neck, which as the wife was demonstrating. Repeated non-rhythmic jerky movements of the abdomen. These are the findings. So, any questions you want regarding the findings of history? I will tell that. Then what do you think the patient may be having?
Could be a multiple system atrophy or a autoimmune encephalitis involving the brains.
Multisystem atrophy, he had no either extrapyramidal or cerebellar involvement, truly speaking.
Tandem walking defective, no?
Mild ataxia is only tandem walking is defective and he's drowsy most of the time.
Androcortical sleep disturbance.
Yeah, but androcortical?
Yeah,
actually he's drowsy, not because real androcortical. He's on the when he becomes drowsy progressively, the neck will come down.
Could be a brainstem autoimmune encephalitis like ECON or DPPX.
Yeah, right, very good. That's a possibility.
So the diencephalic syndrome, sir. Diencephalic hypothalamic midbrain lesion could be some autoimmune or paraneoplastic.
Okay, paraneoplastic, very good.
Iglon 5, sir.
Any other possibility?
Iglon 5.
Iglon 5, very good. Then anything else?
CJD.
CJD is another good possibility you have to keep in mind. It has got some myoclonus as well as drowsiness, mild cognitive impairment. You have to keep that possibility strongly in mind.
CJD or GSS?
GSS is little unlikely because there's little long pose with cerebellar ataxia is a dominant one.
CJD, FF, fatal familial insomnia, rarely.
It's the other way around. He has got excessive somnolence.
Anti-NMDAR encephalitis.
Pardon?
Anti-NMDAR
autoimmune
encephalitis.
It started with the insomnia 5 months back.
Pardon?
It started with insomnia 5 months back.
Correct. Subsequently went into hypersomnolence.
Yes, sir.
Sir, any possibility of DLBD?
No, in fact, his picture was not like a dementia with Parkinsonism. It's actually what is the main cardinal feature is the sleep disturbance. And then abnormal movements in the patient. And these are the two things by which you have to base your diagnosis.
How is the thyroid, sir? Thyroid?
The investigation will come in.
Motors.
Okay. So,
there is thalamus, hypothalamus, and midbrain reticular formation. Those regions are the sites. Could be anything.
Yeah, correct. So that antibody mediated paraneoplastic syndrome can present like this: hypothalamic involvement, brainstem syndrome, drowsiness.
Any chance of Hashimoto's?
Hashimoto's possible. Okay, but this is the possibility I considered. Autoimmune encephalitis, very paraneoplastic, or not, paraneoplastic or non-paraneoplastic. And as you all thought, I also considered Iglon 5 is the top possibility. And some kind of a metabolic encephalopathy they also had in mind because of the myoclonus and the drowsiness. And the other thing is CJD. I think the same possibility which you thought, I also thought. But I was considering Iglon 5 as in the forefront. So I think I'll briefly mention about 2-3 sentences about Iglon 5. I think I'll skip this slide. Now, let us see whether this can fit in with our clinical possibility of Eglon-5. See, the clinical phenotypes are, one is a sleep disorder dominance, and second is the Barbar syndrome, third is a PSP-like syndrome, and fourth is the cognitive disorder with or without chorea. These are the major syndromic diagnosis, the clinical phenotypes of Eglon-5. Other phenotype presentations are MND-like presentation and stiff person phenotype with muscle stiffness and hyperexia. So the core of the clinical presentation consists of sleep disorder, bulbar symptoms, and gait abnormality, followed by cognitive dysfunction. The sleep disorders may include insomnia affecting the sleep onset, fragmented sleep followed by excessive daytime sleepiness, vocalization, this patient had vocalization, abnormal limb movement, this also this patient had, jerks, snoring, sleep apnea, and stridor during sleep. Gait abnormality, imbalance, and retrolateral pulsion. Some of them tend to have gait freezing. And gait problems can be mild, moderate, or severe with frequent falls. Then Barbar syndrome forms the third most common set of symptoms characteristic of Eglon-5 disease, which may be in the form of dysphagia, which very often leads to substantial weight loss, dysarthria presenting with hoarseness and vocal cord palsy and laryngospasm, and central hyperventilation. The other common symptoms include oculomotor abnormalities such as vertical and horizontal gaze palsy, nystagmus and ptosis, dysautonomia, movement disorders like hyperkinetic or hypokinetic, and compress of chorea, bradykinesia, tremor, dystonia, myokymia, and myarrhythmia. They are very often seen in craniofacial areas, but can be present in any body region and even be generalized. They can cognitive decline and neuropsychiatric symptoms such as hallucinations, cerebellar symptoms, and even painless involvement has also been described with muscle weakness, stiffness, and fasciculation. So the course can be chronic in most cases, develop over years. However, it can also be subacute or even acute over weeks. So this can fit in with the Eglon-5, and I will show one video from Neurology where the Eglon-5 patient showing. Look at the trunk.
No, just for a doctor, not an attorney.
The movements there.
I can't say I'm a father take it through. You can't imagine.
The other presentation is second. I think I'll skip this presentation, and rigidity. Another presentation, mentioned. So this is the thing I had in mind. So the investigation is done, but it is already done from outside. So I did not repeat. The blood chemistry was normal. Peripheral smear was normal. Then the calcium 9, thyroid stimulating TSH was normal. Ultrasound abdomen, I'll show that later. MRI brought by the patient. This MRI brought by the patient. This is the entire sequence. This is the T2. This is the diffusion and ADC order. Diffusion is not ADC. This is the abdomen. It is essentially normal. X-ray test is also normal. EEG was done, which is not a normal EEG. So in fact, the CJD possibility became much less likely. So CS was also done. We showed a cell count of 2 because I had strong possibility of autoimmune encephalitis. Protein 89. I don't give importance for protein. This is from my hospital. It all comes as high. Sugar is normal. So what do you think now? What do you want now? So I think the possibility of CJD becomes much less likely. Metabolic workup also was normal, so that possibility also unlikely.
So, serum ACE level, sir?
ACE level, I don't think so. It was done because it was done from outside, no major hospital. They had done every investigation, so must have been done. I do not have the report with me.
What was Romberg's?
The paraneoplastic panel.
Yeah, Romberg's was mildly positive.
Actually, the cause of absent reflexes.
No, because the problem is, of course, I agree with you, except for the trices or reflexes are absent. Sometimes diabetic patients can have diffuse hyperreflexia, but curiously, the triceps was well preserved. But the point is that this areflexia has nothing to do with our patient's problem. Now, he has presented with hypersomnia and then involuntary jerky movements of the body. So that can't be explained by whatever be the cause of hyperreflexia. It may, if it is, can give a diagnostic additional clue if there's some condition is there, but we have to concentrate mainly on the other symptomatology.
Sir, other one rare possibility, if you structure imagination,
yeah,
on narcolepsy, cataplexy, etc. also to be considered.
Yeah, agreed.
The paraneoplastic panel.
But the problem is 70 plus and 3 months history.
That is seen, sir.
That's right.
Exactly. If you structure imagination, sir.
Yeah, and the jerky movement seems very odd for a.
It is some amount of some type of cataplexy.
No, cataplexy is not behaving like that. Cataplexy is actually rocket attack. And from slump to the. This is an active jerky movement. Look at the abdomen. Jerky.
One needed to be kept in mind.
Yeah, I can keep the possibility. Definitely, you can keep the possibility in narcolepsy.
Any history of
paraneoplastic?
Was Siglon 5 done? Antibody.
So let us see the course now. So what all I have done, I will show that. It's a story, long story. Okay. So this is the first stage. This will be we are in the first stage. So
all body PET.
Yeah. So what I did, I sent for paraneoplastic profile and Siglon 5. Both I sent. Autoimmune profile as well as Siglon as well as paraneoplastic. And since I had considered the possibility of an autoimmune possibility very strongly, I put the patient on IVM even though he's a diabetic. And Leorasal for his myoclonic so-called hiccups. In fact, improved partially. But 2 days after during hospital stay, after the stay, patient had chest pain. And a cardiology consultation revealed acute MI in the hospital. Since the patient wanted to go to see his own cardiologist from another hospital, from where he has come to me, he said, I wanted to go there for cardiac treatment, not here. So, okay, he was referred back to the original center where he came from, where he prepared, where his preferred cardiologist was there.
Hello?
He was
Hello?
Hello? He was admitted there for 2 weeks. And when his cardiac problem settled, he was readmitted again in our hospital. During the 2 weeks, during the hospital stay there, he underwent some investigations which are given below. He underwent a PET scan because they thought we may one possibility to be a paraneoplastic. So he went and underwent paraneoplastic workup. Sorry, PET CT. This is a PET CT. Just everything done. There is no abnormality was seen. Age-related corticocerebral atrophy, FTG, a bit small hypotenuse nodule, the thyroid, mild to moderate cardiomegaly, and there is no metabolically active lesions could be found out. Ultrasound abdomen and pelvis is also done, which also inconclusive. This 1.1 prostatomegaly was seen and suggested PSA. Then NCS and RNS was also done. They probably because of the hyperreflexia. They found the peroneal CMAP amplitude and tibial amplitude were low. Other nerves are all normal. So most likely part of a diabetic neuropathy. Sensory potential also absent in the lower limb. Even the upper limbs were normal. FCS is also normal. They did RNS, it's also normal. There is no decremental response. So these investigations were done during the 2-week period when the patient was admitted into the hospital. So by the time the autoimmune profile came, when he came back to my hospital, the autoimmune profile already in my hand. And this is the autoimmune, this thing, GABA, B, NMDA, contactin, AMBA2 all negative. Reglone 5 was also negative. So that deflated my diagnosis. I thought very strongly in Reglone 5. So it was not proved by the antibody testing.
Paraneoplastic panel?
That is also, they did already paraneoplastic as well as a PET CT. So that did not reveal anything. So this is the examination the second time. Second day he was already sent on, initially I put him on steroid and Leofen. He's become clinically much better now with that treatment. So he was at that time from that hospital, he was on after the steroid, he was put on Defsa plus Leofen 10 milligram BD. That is the dosage when which he came back. Look at the patient now, is brighter. So the findings are all same. I think I'll fast forward the video. But the abdominal jerky movement was persisting. But less than what was there initially. It was already on your see there. They are normal because they are just like previously, nothing difference. Prices for eligibility and agriculture same as well. I'll fast forward that. It again almost is little more alert now. So patient improved slightly, but the so-called hiccups of the diaphragmatic macronas continued. So after admission to the hospital, there came.
That was testis screen, testis ultrasound.
Pardon?
Testis ultrasound, ultrasound of the testis.
Testis. Anyway, they done already PET scan. I don't know whether that's required.
PET scan will not detect testicular cancer, sir.
Okay. That thing I did not struck my mind. Anyway, that's a good possibility. We have to do that.
NMO was not.
NMO, I don't know. NMO was also done. The coupering, the autoimmune antibody, but I did not then think of. I did not send that this one. The MRI did not find any findings suggestive of a demyelinating disease like NMO. Spinal cord.
Ammonia value, sir. What is the ammonia value still? Okay.
I'll come to that. That's a good possibility you have to keep in mind. So I'll come to that. The story does not end here. This is only 1/3 of the story is over now. So what will you do? So because they're seeing the myoclonus, I given the 3 more injections of IVM. Initially 2 was given. And increased the dose of Leofen to 112 because initially it produced some improvement in the diaphragmatic myoclonus. And Seligelin and modulate for its excessive drowsiness. A repeat MRI was done with thin cuts to look for any brainstem lesion because there's a diaphragmatic myoclonus was there. So I thought I will look for any lesion in the brainstem, glenomedullary triangle to account for his persisting hiccup. So I did for the brain that was normal.
പേഴ്സണലാണ് സസ്പെക്ട് ചെയ്യുന്നത്. മെഡലിലായിരിക്കും.
This is the player. Again, I took the T2, no brainstem lesion, but we'll see. And this is the coronal cut.
അതൊരു abnormal-ആണ്.
That's normal. There's nothing abnormal. Prayer was also meditation was also normal. So repeat MRI, look for any in the brainstem was normal.
T1 was done, sir. T1 for T1 for any hyperintensity of the basal ganglia, like a chronic.
No, that is basal ganglia is entirely normal. Nothing abnormal was seen. Because I looked at the one possibility initially kept to a CJD, so I kept that that is normal. So about 1 week, after about 1 week, patient went into excessive drowse state after I increased my dosage. Initially came with little more bright. Now he developed excessive drowse and developed flapping tremor. So this is patient. Yes, he cannot keep his arms straight because of the flapping. He might So what will you do now?
Ammonia, sir.
Ammonia.
Sir, stop the baclofen and do the ammonia and pitena.
Baclofen stop.
So first of all, we have to find out what is causing his flapping tremor. So did an EEG. EEG showed these classical triphasic P complexes, showing a metabolic or toxic and sublevel. So now very confidently, this is a triphasic P complex, okay. Then stopped Leofen and Seligetin, okay. And then was sent for metabolic workup, including serum ammonia. And sometimes, hepatic dysfunction can be made out only by ultrasound. You may not even ammonia may be known. So I sent that also ultrasound abdomen. The ammonia was normal, 2.28 only. Other metabolic findings are also normal. Ultrasound abdomen was also normal. So I stopped the medication and patient improved on the second day after stopping the medication. And I repeated the EEG and EEG turned back to normal. So we clearly know, clearly related to the drug the patient was taking. The stopping the drug patient became normal. What happened means, on stopping the Leofen, the jerky movement increased. So I waited for one more day, and but however, the patient's sensorium has become much better because after stopping, because the metabolic encephalopathy is improved after stopping the medication. But during the hospital stay, he developed severe distress because he was not able to sleep because of his so-called breathlessness. And the called the duty doctor at night. And what they saw was his repeated hiccups, his worsened. So the duty doctor, what did you do? Seeing that, I'll tell you, the worsening of the hiccup, the more worse. So I restarted him on Leofen and ingested metoclopramide. Next day, so this is at night. Next day, I increased the dose of Leofen to 1 tablet BD and changed metoclopramide to ondansetron, Emiset. Think that's a hiccup. But his symptoms persisted. So what will you do?
Clonazepam, sir. Clonazepam.
Clonazepam initially was given with 0.2 mg clonazepam. He went totally out. He knocked out. Some people don't tolerate clonazepam. Because basically he has got a problem by excessive drowsiness, no?
Yeah.
In fact, I put them seeing my clonazepam. One dose enough. That was he was knocked out. They did not try subsequently.
That shall I tell, sir?
But
Area posturing and narcolepsy syndrome.
No. But what the MR is normal. That's why checked again. Pardon?
CSF NMO, sir.
CSF NMO, serum NMO is more reliable than the thing. But I do think there is a NMO is to indicate in this patient with this presentation with absolutely.
Area posturing and acute narcolepsy like a presentation.
Okay.
The mild response to steroids and the patient then worsening could be a part of IGLON 5. And all patients need not be antibody positive.
Okay, that's the thing I had also in mind. And I was thinking some kind of automatic and said, put the patient again on a steroid, IVMP, even after the results of IGLON 5 has come negative.
Sir, any possibility of Whipple, sir?
Yeah, but this is a possibility, but the classical eye findings and things are not there.
Sir, these are abdominal myoclonus or abdominal myarrhythmia. Sir, the movements
It's a jerky movements. It's a jerky movements, myoclonic movements.
Sir, trial of plasmapheresis or IVIG.
Okay, so let's see that as the story evolves. Now let us see what will things happen.
Sir, any drug-related complications, sir?
Pardon?
Levetiracetam, did you try? Levetiracetam.
Levetiracetam can be given for this myoclonus, but I'll come to that story later on. So what I'll do, now my question was, what is diaphragmatic myoclonus cervical cord pathology? See, that's another thing you have to keep in mind.
Could be, because C3, C4 irritation also can be.
Yeah, irritation is the one you have to keep in mind. It's also some kind of a myoclonus, irritation of the diaphragm. So should I do MRI of the cervical cord? We just not done so far.
Yes, sir.
Okay, Bindu wanted it, so I'll give you Bindu MRI of the cervical cord. It showed the hypertensity, overtensity, myelomalacia changes. Can you see that? With the disc.
Yes, sir. C4,
Okay, that's its sagittal cord. I'll show the axial cord. That's a compression of the cord, and then cord is flattened at that time. Did you see that? Cord is flattened at that time.
Yes, sir.
Okay, what will you do?
That doesn't explain the abdominal
Cervical collar and treatment for
Cervical collar.
Evaluate first. Anyway, that would explain the sleepiness, sir.
Sleepiness.
The excessive sleepiness as well as the other cognitive changes cannot be explained.
Cannot be explained.
Any hypoxia or hypercarbia going on?
No, that can cause that, but as Parameswaran was telling, so these symptoms of sleepiness are even very big at the very beginning. That is difficult to explain with that. So overall, there may be some autoimmune phenomenon going on, and this myoclonus is part of it. Agreed with that. This cannot, but he can explain these things. All other things are improving, but this myoclonus is the one which is persisting. That is why we went to cervical spine. Okay.
But how common is cervical cause for abdominal myoclonus?
No, it's a diaphragmatic myoclonus. Hiccup like presentation.
Is it common, sir? Is it common?
No, it's not common. No, the thing is that nothing. It's not at all common. I had not seen one. Agreed with you. But the thing is that we are chasing it, facing to find out a cause. What is causing this person's jerky movement? It's not subsiding.
The repeat paraneoplastic panel.
Okay.
Any drugs, sir? Any drugs, sir?
Only the drugs which he is receiving is now this one. All other drugs have stopped. Okay, let us see what will you do. In fact, for the 2-3 weeks, I have been thinking about this case only. So I was wondering whether it is really a diaphragmatic myoclonus or not. That's the next question. So because there is a lesion in the cervical cord, if it is really a diaphragmatic myoclonus, that could be the culprit. Other things are there which may be due to some other reason. So what I did a fluoroscopy to find out diaphragmatic movement, where you can find out. So I took the patient to the cath lab. Diaphragm movement is normal. There is no
normal movement. അല്ലാതെ ഇടയ്ക്കൊരു അബ്ഡോമിൻ ചെറുക്ക് വരുന്നതെന്ന് അറിയണം.
So no abnormal movement of the diaphragm was seen. They looked at the abdominal wall. The abdominal wall was showing irregular jerky contraction. The same fluoroscopic concentrated. That's a organ jerky movement.
Abdominal wall movement, diaphragm.
Correct.
Yes, you can see the abdominal muscle moving.
Abdominal wall also moving.
That shows its abdominal wall is moving, not the diaphragm. So far we have been thinking about hiccup and diaphragmatic myoclonus and so now we know it is not due to any diaphragmatic contraction. Its abdominal wall is contracting. So what will you do to confirm?
EMG.
Okay. So EMG was done. So the first adrenaline activity along with that's about it.
Both should come in. The banking architect, the contact are
The abdominal contact is
ഒരു മിനിറ്റ്
hold the breath and then look at the contact release first.
പഠിക്കല്ലേ ഇനി വിട്ടോ ഈ ശ്വാസം വലിക്കല്ലേ
So I asked him to hold his breath and again the discharges were coming, proving conclusively that this is coming from the abdominal wall and not from the diaphragm. So this is from the literature showing this kind of a burst in segmental myoclonus. So I put him on sodium valproate and gabapentin and stopped Emicet, which he is receiving. Emicet is on syndrome, and increased the dose of leofin a little bit. Now the question is, it's got a abdominal wall myoclonus. So that means it's something like a segmental myoclonus. That most of the time, segmental myoclonus per se is due to some cause in the spinal cord. So you have to imagine for the dorsal spine. So MRI dorsal spine was done. This is the T1, T2, this is the axial T1. This is again T2. This is the coronal cut. No lesions in the dorsal spine. Lumbar spine is also done just because see that's also plain up. I'll skip that. So patient improved remarkably with leofen and gabapentin. This is the video. This has become much less. This is 2 days later. He's still in the ward. Patient is in the ward. He's getting discharged. No macronus at all. Absolutely not taken. So probably his excessive somnolence, or the etc. could have been due to hypercarbia secondary to this breathing problem caused by his abnormal, because it is so frequent at night. That is why he is sleeping most of the time during daytime, because he could not sleep on lying down. That's my contention. I do not know is I'm right or not, because taking the whole picture in the consideration, I mean, coming to that conclusion. Because now he is fully conscious, no memory problem, is working normally. Macro cells have subsided. He has stopped all medication except for small dose of leofen and gabapentin. This is
APG was done to show hypercarbia.
No, that is not. It's only see, these are all my conclusion now. At that time, when he had having breathless, that was not done looked into by anyone. Nobody thought of that possibility.
Sir, the hypercarbia need not be there. He just must have lost his sleep because of the excessive contraction.
Yeah, that may be the reason. That may be why he's drowsy most of the time. And probably contributed by the antipsychotic medications which the patient has been receiving. It has stopped after.
So could it everything be functional, sir?
No, not at all. Because we have proved the myoclonus, not diaphragmatic myoclonus.
So the triphasic waves,
yeah.
When you gave Liafen, we had triphasic waves. That did not repeat again.
No, that disappeared. Liafen, the triphasic wave disappeared totally. And with the flapping terminal also disappeared on decrease the dose of Liafen. I started increase the Liafen to 112, 4 tablets.
Oh, that is the time. Okay.
That's the time when you develop this flapping tremor and this thing. Final diagnosis segmental or spinal myoclonus. So last class somebody asked me about, I think Feroz must have asked me about the proprioceptive myoclonus. No? So I'll tell you about some few words about that also in this class. Before that it's a case of a segmental or a spinal myoclonus. Refers to involuntary brief rhythmic contraction of group of muscles separated by one or more contiguous segments, either in the brainstem or the spine. And usually they have got a cause like trauma, spondylosis, tumors, infections, myelitis, ischemia, etc. Now, the spinal myoclonus can be of two types. One is segmental, or called a spinal segmental myoclonus, where it's affecting only 1 or 2 segments, or so-called proprioceptive spinal myoclonus, reflecting spinal segmental organization and the presence of propriospinal pathways which connect different spinal segments. It is generally resistant to supraspinal influences such as sleep, therefore it may persist during sleep, or voluntary action, therefore it is present at rest independently of activation and may or may not be stimulus sensitive. Now the spinal segmental myoclonus, as our patient was having, not the proprioceptive one, is usually symptomatic of an underlying structural lesion such as syringomyelia, myelitis, spinal cord trauma, vascular lesion, or malignancy. It is confined to one or few contiguous myotomes and may occur irregularly or quasi-rhythmically with a frequency as low as 1 to 2 per minute or as high as 100 to 200 per minute. EMG the myoclonic bursts are prolonged up to 1,000 milliseconds. Now coming to the other spinal myoclonus, is proprioceptive myoclonus. It's a form of spinal myoclonus where the spinal generator recruits axial muscles up and down the spinal cord via long propriospinal pathways. Propriospinal pathways are pathways within the spinal cord connecting multiple segments. Typically, there are axial flexion jerks involving the neck, trunk, and hips with a frequency of 1 to 6 per 6 hertz. EMG burst, unlike the segmental spinal myoclonus, is long, lasting for several hundred milliseconds. Clinically, it can be distinguished from brainstem myoclonus, which is also axial in distribution, but sparing the face and insensitivity to auditory stimuli. It occurs typically spontaneously, especially in the recumbent position, or may be provoked by tapping the abdomen or by eliciting tendon reflexes. As opposed to segmental myoclonus, most patients with proprioceptive myoclonus have no clear etiology. Symptomatic forms are reported in the cervical trauma, tumor, myelitis, etc. And as told last class, some of them do not consider it a real entity. But psychogenic forms of proprioceptive myoclonus also now increasingly recognized. Now, this is again from literature. I think many of my, I also not seen very clearly typical proprioceptive myoclonus. This is one case from the literature. Please look at the patient's proprioceptive myoclonus. This is from the Green Neurology Journal. See, this is a proprioceptive myoclonus. Spreading axial muscles. So this is spread from below upward.
This is proprioceptive or propriospinal?
Same thing. Propriospinal myoclonus. So they're not proprioceptive, propriospinal. This is a propriospinal myoclonus. Again, forget about this. I think the various causes. See, from the literature, a hiccup-like seminal myoclonus in the thoracic compressive myelopathy case report, just like our patient. But our patient did not have any secondary cause of the spinal cord. This is the same patient showing a lesion in the thoracic cord compressing, causing the hiccup-like segmental myoclonus.
So we can explain the same thing with the high cervical cord lesion, isn't it, sir?
Yeah, but our patient did not have any irritation of the cervical segment. It was the thoracic segment. Because of
I mean, just like the sensory symptoms, this manifestation may be due to a high cervical cord lesion.
No, that cannot. No, it is due to the irritation of the anterior cells. No, this is previously some of these, most of the cases were attributed to. Some of them are reversible, spontaneously remitting, and this is the diagnosis which was thought of: subacute myoclonic spinal neuronitis. So they are self-limiting conditions. This is from the literature, limited to abdominal muscles, short duration. And this is another case showing variable contraction of all the muscles, abdominal bone and legs due to spinal neuronitis. They're self-limiting conditions. Okay, now coming back to Umar, what you was telling?
Oh, so my question is, just like the sensory symptoms in the legs and in the abdomen, because of the high cervical cord lesion. So can we postulate the same symptomatology, the myoclonosis?
No, that cannot. If it were myoclonus should occur, should be in the arm muscles. Then only you can explain by the cervical lesion, or should be the diaphragm where it arises on the C3 segment.
Here we can, sir, because the lesion is high up, and that can explain the spine.
No, here it's a thoracic segment, not this abdominal wall myoclonus segmental. So it should be affecting the thoracic cord.
Sir, okay, sir. Yeah.
That is the reason why I did the fluoroscopy to find out where this jerk is coming from. Is it really from the diaphragm? In that case, I could explain by that lesion which I already seen the cervical MRI. But if it is abdominal myoclonus, that cannot be explained by a cervical cord.
Initial part of the history.
Initial part?
Of the history, there is increased drowsiness and some features to suspect something like an encephalopathy.
Yeah, in fact,
so
you know,
the picture.
The
Can the entire picture, due to progressive encephalomyelitis with rigidity and myoclonus?
No, it's not like a perm. Perm presentation is not like this. Here the myoclonus is confined only to the thoracic segment only. So it's not like a perm. Perm has got a stiffness and sensitive spasms. And there are other things also in encephalomyelitis partly. But here, actually, there is no lesions in the brainstem or the EEG or the brain MRI repeatedly. Nothing was there. CSF is also normal.
What could be the reason for memory loss since 1 month?
See, that's perfectly agree with you. That is why initially we all thought he has got cognitive impairment, jerky movements, excessive drowsiness. We thought autoimmune encephalitis, like Iglon 5. That is what I initially thought. But retrospectively thinking, there was no evidence to suggest an encephalitis investigation-wise. The only abnormality hymenal function was his clock drawing abnormality. He was also at that time also you see that even drowsy. Probably that can hamper his executive function also.
Okay.
That jerky movement of the neck disappeared.
That was not there when he came to us.
Okay.
It was only the abdominal muscle.
Imbalance while walking also, that could be due to this compression.
Yeah, maybe very unlikely because his otherwise gait is normal. There's no spasticity, no criminal signs, panda down weighing. They have definitely evidence of myelopathy. Probably is drowsy most of the time. That is why he's having some mild imbalance can occur even if you're drowsy.
The extension movement of the neck with the eyes also going up. What was that?
No, I do not know. That is what the wife described. You can see that thing. Was it a hypnic jerk at that time or we do not know? It's occurred only during sleep. That was not seen during daytime.
And so did you say he improved with steroids?
Was the improvement due to steroid? Maybe, I do not know. But very unlikely. Probably I think that when the myoclonus subsided, everything became all right. And probably his improvement was due to the withdrawal of all his antipsychotic medications.
Thank you.
But neck movement may also be due to antipsychotic, maybe some.
Maybe due to that thing.
Could it be the delayed side effects of any antipsychiatric drugs? Everything.
This kind of a jerky movements, no. This no kind of jerky movements not due to that. You can have dyskinetic movements like Stephen movement, but this is like a myoclonus. This is not like a drug-induced dystonia or a dyskinetic movement. Anyway, that is an interesting case, which put me in a lot of trouble in the sense that a lot of time for me to conclude what the case was.
That is really interesting, sir.
Yeah. This is how, this is the thing which we all face, in real practice. We may think it's like maybe do dentally due to things like that. And among the host of other things, there may be one finding like this segmental myoclonus, which may be the only culprit. Other thing may be due to the coexisting metabolic factors and drug-induced factors, etc.
Would that be tardive myoclonus?
Maybe, I don't know. Maybe you can say that. I don't see like myoclonus like this.
But there is an improvement right now. So that cannot be tardive because this sort of improvement is unexpected.
Myoclonus only, it can improve even if it's tardive, it can improve.
But completely disappearing is unusual, isn't it?
Yeah. It disappeared. With that drug, drugs only it disappeared. It was on gabapentin and levorsen.
Gabapentin.
Sir, do you use selegiline for excessive sleepiness?
Yeah, that's one of the best drugs for drowsiness. Initially, before the Moderate came, I was rarely using the selegiline. Because the selegiline, but not rasagiline. Rasagiline will not produce awakeness. Because one of the metabolic product of selegiline is amphetamine. And
But
it's
it's
the metabolic
available now. So Seligane is available right now.
freely available.
Okay.
Freely available.
No, we were using, but after the Rasalect,
It is very easily available.
Yeah, it's available here also, Trishur also.
Yeah, it's available. Whatever. I've been using it right and left from the very beginning. At 10, 20. Even it's available in the ward also. It's available. It's a good drug for narcolepsy also.
So why gabapentin was given for control of myoclonus?
Myoclonus.
But actually, it can produce myoclonus also, like in renal failure. And
You can try levetiracetam, which I put sodium sulfate also in this patient. So rather than try 2-3 things, I don't know which drug to give. Because it's actually due to the irritation of the anti-horn cells, no? It's myoclonus. So we can give a drugs like something which suppresses that thing, or drug which really for myoclonus. Okay, shall we stop? In fact, I wanted to bring other cases from Joy also, but today I don't have time for that. I'll show it next week. Okay. Any questions?
Thank you very
Thank
much.
you, sir.
Thank you,
sir.
Good night.
Thank you, sir.
Good night.
thank you, sir. Good night.
Good night.
Good night, sir.
Good night.
Nice.
Good night, sir.
Good night.